individualization of Luteal PhaseSupport where we are.
Thanks for the introduction. Good morning, and it's my great honor to have presented here about individualization of RPAs. There is a Chinese proverb saying "발음빙징," which means the perfect basket touch. I think RPS is kind of 발음빙징 because we are kind of artists, and doing ART, we stimulate and open pickup, embryo transfer, and lastly, Luteal PhaseSupport. With this, we can get live birth. Then I read the Luteal phase in IVF cycles. In natural menstrual cycle, a single corpus luteum is formed from the dominant ovarian follicle. And at 8 to 9 weeks gestation, of the corpus luteum is a primary progesterone reservoir during pregnancy shifted to the placenta. So we call it luteal placental shift, and this means that critical role of corpus luteum is until 7 weeks of gestation. In ART cycles, there can be luteal phase defect, and the most important factor is that in IVF cycle, we use superphysiological dose of FSH for ovarian stimulation and increase the luteal phase serum estradiol levels, suppress gonadotropin, causing LH deficiency. As a result, compared to natural cycle, shortened the median luteal phase from 13 to 11 days in IVF cycle are observed. Moreover, in gel-agonist long protocol, it can take up to 2 weeks for genetic receptors in the pituitary to be renewed. Actually, in this study, luteal granulosa cells in IVF cycles, particularly those of gel-agonist triggered antagonist cycles, compared to natural cycle granulosa cells, express low level of LH receptor and apoptotic genes. As a result, they undergo apoptosis earlier and fail to maintain estradiol and progesterone production. Because physiological steroid levels are primary cause of luteal insufficiency for IVF, to investigate the impact of suppressing estradiol levels during ovarian stimulation, retroviral treatment during ovarian stimulation in gel-agonist triggered oocyte donation cycles were tried, and with this retroviral treatment, serum estradiol level at day 5 after oocyte retrieval decreased from 3,000 to 2,000, and higher level of progesterone and a longer luteal phase was observed. Number of retrieved oocytes was not different. Similarly, in this trial, retroviral treatment during ovarian stimulation with gonadotropin in IVF was observed, and similarly, there is no impact on follicle recruitment, number of oocytes retrieved, quality of embryos, and ribose rate. So we can summarize that supraphysiological serum levels of estradiol during IVF can negatively feedback on LH, and then reduce the luteal progesterone level and duration of the luteal phase. In the trial of retroviral reduced these detrimental effects, but did not improve the ribose rate. When you read the effect of the trigger on the luteal phase during IVF, by ovulation trigger through LH-like activity, we can induce oocyte maturation and support formation and survival of functional corpus luteum. HCG directly bind to the LH receptors on the corpus luteum, and HCG has longer life than endogenous LH, and 5-fold increased potency at the LH receptor. So, in the absence of LPS in HCC trigger, serum concentration of progesterone peaked about 180 nanomole per liter on day 4 after HCC trigger. Then progesterone levels began to decline when HCG levels dropped below 30 IU per liter, making neither. To compensate this neither if increase or at the HCG injection, this can increase the risk of ovarian hyperstimulation syndrome. In GERD agonist trigger, GERD agonist stimulates the pituitary to release endogenous areas. Then GERD agonist induced shorter duration of LH secretion compared with natural LH surge or the LH-like activity provided by HCG. So, with GERD agonist trigger, serum LH levels rise to 140 IU per liter at 4 hours, then return to baseline just within 36 hours. Because of this short duration, low risk of ovarian hyperstimulation in women with PCOS or high responders are possible. But corpus luteum can survive short period without LH-like activity, so defective corpus luteum can be induced with GERD agonist trigger. As a result, shorter luteal phase and low serum progesterone levels are observed compared with HCG trigger. So, greater attention to luteal phase support in GERD agonist trigger cycle is required than in HCG trigger cycle. Then I read how to optimize LPS in phase cycle. This Cochrane is the key data, and with this latest Cochrane data analysis and recent subsequent RCTs, they all demonstrate the clear advantages of LPS on ribose rate. But despite these numerous studies, still no concrete consensus on the optimal LPS regimen for improving ribose rate. In considering this, we should review the timing, duration, and dosing. First, timing. When we read the role of progesterone in implantation, it induced endometrial desolarization, and through this, increased the surface area or promote adhesion and invasion of the blastocyst. And progesterone modulates immunization to offset and tolerate semi-allogenic features. So, modulating both uterine and systemic immune system is equally important. Because it takes time for progesterone to activate and suppress the transcription factors, cytokines, growth factors, and cell adhesion molecules, there is a concept of window of implantation. This spans about 30 to 36 hours and usually occurs 6 to 9 days after the LH surge in the natural cycle or 4 to 7 days after progesterone supplementation in ART cycles. Studies are saying that miscarriage risk increases above 6 times if implantation occurs outside this window. According to the meta-analysis, initiating LPS before ovum pickup resulted in a significantly lower critical clearance rate, and comparable ribose rate results were observed when LPS was started between ovum pickup and embryo transfer. According to this result, the latest ASIO guidelines stated that starting of progesterone for LPS should be in the window between the evening of the day of oocyte retrieval and day 3 post oocyte retrieval. But you can say still this is just good practical point. And according to the worldwide survey-based study, LPS is usually started on the day of own figure or the day next. So I think there is little disagreement regarding the timing of LPS initiation. Next topic is duration of LPS. According to this meta-analysis, including 6 RCTs, stopping progesterone at the time of pregnancy test versus continuing until 6 to 7 weeks were compared, and there was no significant differences in divorce rate or ongoing pregnancy rate. According to the more recent meta-analysis, clinical outcomes including divorce rate, ongoing pregnancy rate, and miscarriage rate all were similar between early progesterone cessation and continuation. But according to the survey-based study, progesterone was administered until 8 to 10 weeks gestation by 35% of the respondents, and until 12 weeks by 42% of the respondents. Then what would be the possible reason for this discrepancy with evidence-based medicine? I think with the increased use of gene trigger or programmed progeny, clinicians may be accustomed to using more and more intensive Luteal PhaseSupport. And actually, some doctors may fear being blamed for not using longer Luteal PhaseSupport as other women when pregnancy outcomes are not favorable. And according to this Cochrane review, most studies on this topic utilized our HCC trigger. But as we discussed, more extensive Luteal PhaseSupport in Janus agonist trigger cycle is required in HCC trigger cycle. Combining these results, the WHO guideline suggests that progesterone for LPS should be administered at least until the day of the pregnancy test. Actually, they made no restriction on how long the drug could be used. In aspect of Luteal dose, actually we can use various route of oral, vaginal, rectal, intravascular, and subcutaneous progesterone, and recently we can consider progestin of dydrogesterone. According to WHO guideline, given the according to the Cochrane review database, given the lack of definitive evidence favoring modulation over another, they suggest that any of the previous mentioned administration route, not oral for natural progesterone as LPS, can be used. As a result, the choice of LPS route or formulation would be selected by patients and clinicians' preference. And in this case, we should consider that safety data on oral dydrogesterone was not sufficient at the time of 2019. Vaginal progesterone is the most widespread form for LPS, and global survey revealed that 80% of IVF clinicians currently favor vaginal Luteal PhaseSupport. This formulation have uterine-space effect, so have higher endometrial level but lower steady-state serum levels. The limitation of this formulation is sometimes it causes vaginal itching or irritation, and we can try another route. And vaginal care, in vaginal care, there can be leakage, and this can decrease patient compliance. Intramuscular progesterone has higher serum level than vaginal formulations, but lower endometrial levels, and it can contribute to more systemic effect. The limitation of this formulation is it requires assistance to administer, and it can be very painful and occasionally lead to abscesses, which is very severe. In contrast, subcutaneous progesterone is water-soluble formulation, so it has faster absorption rate than intramuscular formulations. So concentration peak within 1 hour to 144 nanomolar, and so it has less side effects than intramuscular progesterone. So it is the medication of better tolerated than intramuscular progesterone. Oral progesterone is less favored due to extensive process effect, and because of this, lower and variable metabolic bioavailability is observed, and adverse effects like soreness, dizziness, and headaches can occur, and this can lower patients' compliance. But dydrogesterone has higher specificity and sensitivity for nuclear progesterone receptors, and induce endometrial transformation at 10 to 20 times lower dose than oral micronized progesterone. So it has been minimized adverse effects than oral progesterone. Actually, there were concerns about potential teratogenic effect of synthetic progestins, but latest meta-analysis revealed that the causal association between fetal endomyelitis and first trimester dydrogesterone use was observed. And the significant difference in clinical trends and spontaneous abortion rate was observed with oral dydrogesterone and vaginal progesterone. So, oral dydrogesterone can be served as well tolerated and cost-effective Luteal PhaseSupport agent. Lastly, I will Luteal PhaseSupport for frozen embryo transfer. As frozen technique have improved, average IVF pregnancy rate and birth rate using frozen intake increases. According to this UK data, actually birth rate increased from around 6% in the 1990s to 27% in 2021. IVF prevalence and birth rate using frozen increased over the past 13 years, and market shift has occurred toward the frozen cycles over the past decade. So according to this UK statistics, the proportion of frozen increased from 90% of IVF cycles in 2010 to 46% in 2021, and the Korean data reveals the same trend. There are some advantages and utility of frozen ET. Frozen ET differ embryo transfer from the initial fresh site and negate the influence of the proceeding supraphysiological level of sex on the luteal phase that are inherent in fresh transfers. In the risk of high OHSS, Jones agonist trigger followed by frozen ET can be offered. Interest in the practice of single embryo transfer to prevent multiple pregnancies has led to a rise in the cryopreservation of surplus good quality embryo. And in addition, protein allowed sufficient time to conduct PGT. And with the increasing awareness of fertility preservation, the number of cases involving the cryopreservation in of good quality oocytes or embryos are rising. In frozen embryo transfer, there is natural frozen ET cycles and programmed frozen ET cycles. And natural frozen ET cycles can be divided into two natural cycles and modified natural cycle. In two natural cycle frozen ET, following frequent endocrine and ultrasonography monitoring, the Dayong ovulation is documented to schedule the timing of frozen ET. In modified natural cycle, ovulation is triggered with a GCG when the rhythm follicle reaches to the target diameter. In programmed frozen ET cycles, endometrial preparation is induced using estrogen and progesterone. So this method can be adapted to the ovulatory woman, and this method leads to the absence of a corpus luteum. Because there is no active corpus luteum in programmed frozen ET cycle, extensive estrogen and progesterone supplementation is required. Moreover, programmed frozen ET cycles are reported to be associated with hypertensive disorders of pregnancy, fetal microgyria, and gestational diverticulitis. It is hypothesized to be due to the lack of corpus luteum, which are producing angiogenesis molecules like VEGF or relaxin. In natural frozen ET, some studies show that vaginal LPS can enhance ligase rate compared to low LPS. So, even if there is functioning corpus luteum in natural frozen ET, like luteal PhaseSupport can be tried. From survey result, actually 56% of clinicians prescribe LPS for natural frozen ET cycles. In programmed frozen ET, with the lack of corpus luteum, usually progesterone supplementation is continued until 10 to 12 weeks gestation. And some studies suggest that intramuscular progesterone might be more effective than vaginal preparations. For example, according to the study of Divine et al., serum progesterone levels on pregnancy tests were considerably lower with vaginal delivery alone compared with vaginal plus intramuscular or daily intramuscular formulation. This study reported that oral dihydrogesterone alone group revealed significantly lower clinical pregnancy rate and ongoing pregnancy rate. So, oral dihydrogesterone only can be insufficient for luteal PhaseSupport in programmed frozen ET, but there still is controversy. Some studies tried to track the individualized luteal PhaseSupport for programmed frozen ET. In this study, the researchers assessed the serum progesterone level on embryo transfer day, and if the progesterone level is above 29.3, they started standard luteal PhaseSupport, and if the progesterone level is under 29.3, they divided the group into standard LPS or additional subcutaneous progestin group. As a result, in women with progesterone and adding subcutaneous progesterone rescued the ribose rate to the same level at in those with higher progesterone. In monitoring serum progesterone levels with corpus luteum can vary because it has diurnal rhythm, pulsar secretion, and poor cell reliability at low concentrations. And same level of supplementation during LPS can result in different progesterone levels, and serum levels might not proportionately reflect individual levels. So careful interpretation in monitoring serum progesterone is necessary. As I said, in programmed progenitive cycles, there is no functional corpus luteum, so the monitoring serum progesterone can be more stable. In one study, in programmed progenitive cycles, higher ribose rate and a reduced discharge rate were observed when progesterone level was above 31.8 on the day of embryo transfer. And some studies suggest the impact of BMI on progesterone requirement. Our first study, obesity ovulatory woman with fertility is associated with an increase in the time to spontaneous conception by 4% for 1 PMD change. In the second study, serum progesterone level in early pregnancy tend to be lower in women with obesity. In third study, serum progesterone levels on the day of embryo transfer are typically lower in women with obesity than in women with normal BMI. These studies imply that women with obesity might be beneficial from higher dose of PhaseSupport regimen, but yet there are no definite data about this, so further studies are warranted. There are still some unsolved problems, including endometrial progesterone resistance is suggested in women with PCOS and endometriosis, so investigation whether such a phenomenon can be characterized in women undergoing IVF, or whether progesterone resistance affect the outcome of LPS should be further studied. And determination of predictors of the variation in pharmacokinetic properties, including absorption and distribution, should be also further researched. And in non-invasive rapid methods of assessing endometrial receptivity should be further explored. In summary, Luteal PhaseSupport is a critical element of successful ART to support implantation, maintain pregnancy, and optimize ribose rate. As per physiological level of testosterone from the preceding ovarian stimulation disrupt luteal phase. Trigger used to induce oocyte maturation affect the likelihood of sufficient erythroid dispersal needed to form and maintain functional corporal luteal, so more intensive luteal PhaseSupport is required for gel-agonist trigger cycle. And the detrimental effect of the disrupted luteal phase in the first cycle can be overcome by progeny. And progeny do not result in formation of functional corpus luteum and can increase the risk of pregnancy complications such as preeclampsia. So, high dose of vaginal progesterone or intramuscular progesterone should be considered in programmed progeny cycle. And individualized luteal PhaseSupport should be further evaluated according to measurement of serum progesterone levels, or adjustment according to BMI or pictures or individual status. Thank you for listening.
Thank you, Dr. Lee, for a nice talk. Due to time constraint, we will be able to get any questions for this session.
I'd like to introduce the next speaker. It's Professor Dayong, who's well known to you. She's a Dean of the Faculty of Medicine and head of the Department of Sections and Gynecology at the University of Medicine and Pharmacy in New York City.